Good morning. Thanks for coming to join us for Cardiology Grand Rounds. I'm Eric Krieger, as most of you know, and I'm happy to be here to introduce our speaker this morning, Dr. Matthew Cham. Matt, we were lucky enough to recruit him from Mount Sinai in New York City, where he was director of cardiovascular imaging there. Dr. Cham got his undergraduate and medical degree at the University of Rochester, and then did his residency there. He ended up going off to the Royal Brompton to do a fellowship in cardiac MRI, which I believe is it the highest volume cardiac MRI center in the world? In the world, yeah. So a really exceptional opportunity. Following that, he ended up at several institutions, but doing cardiovascular imaging and thoracic imaging at Cornell in New York City, at New York Hospital at the time, and then made his way over to Mount Sinai. While at Mount Sinai, he directed a very busy program doing, he tells me, between 20 and 30 cardiac CTs a day, in addition to about 5 to 10 cardiac MRIs a day, a really impressive clinical program. Academically, he's been a star. He's a professor of radiology here, and has written dozens of papers, given innumerable international talks. He's been voted an exceptional reviewer for top journals such as Radiology. He's been a reviewer for NIH study sections. He's mentored tons of trainees around the country. On a personal level, I'm really excited to be working with Dr. Cham. He's come here from a center with a long history of extensive collaboration between cardiology and radiology, and he seems really committed to building and extending that collaborative attitude here. He's been great in terms of offering opportunities for our trainees to get more exposure to cardiovascular imaging, and that's something that we're hoping to build. From a program development standpoint, Dr. Cham has really solicited the input of our clinicians in cardiology in terms of what we can be doing to better serve the needs of the cardiologists here, whether it's updating our protocols when it comes to tissue characterization, which we'll hear some about today, improving access to cardiac MRI and cardiac CT, or just providing the kinds of analysis that we need to be able to take exceptional care of our patients. So it's a real honor to have him here. I'm glad to have him as a partner moving forward, and I'm enthusiastic about hearing his talk today. So thank you. So Dr. Cham.
Thank you so much. Thank you very much for that wonderful introduction, and thank you all for being here this morning. So today we're going to talk about MRI for myocarditis. No financial disclosures. Just wanted to point out gadolinium-based contrast agents are off-label use for cardiac MRI, and some of the software I'll be showing today are actually for research purposes only and not yet FDA approved for clinical use. So the main objective for today is to review the pathophysiology and clinical features of myocarditis, to illustrate the role of cardiac MRI as an accurate and non-invasive diagnostic modality for myocarditis and its impact on treatment, and also to demonstrate the cardiac MRI findings in both acute and chronic myocarditis. So myocarditis is traditionally defined as myocardial inflammation due to infection, specifically viruses, bacteria, or fungals, toxins, or systemic disease. And viruses are most frequently presumed cause in developed countries, and that's going to be the focus of my talk today. So the indications for cardiac MRI and suspected myocarditis are as follows. They include myocarditis symptoms such as chest pain, dyspnea, palpitations, recent or ongoing myocardial injury, usually it implies troponin elevation or abnormal ECG, and suspected viral etiology, specifically being able to demonstrate that there's no significant coronary disease and age less than 35, for example. So the use of cardiac MRI is typically applied earlier on during the workup of myocarditis, and with the help of cardiac MRI we can decide whether to apply supportive care or perhaps involve endomyocardial biopsies and various types of therapy, and that's where the power of the MRI lies, is to basically be able to stratify and triage patients. So I'm going to go over some typical findings that we see in cardiac MRI and how we use MRI to diagnose myocarditis. One of the main findings that we try to look for is hyperintensity during T2-weighted imaging. So during T2-weighted imaging, the myocardium is supposed to look a bit gray, just like this. And in areas with myocardial edema, you see increased brightness, increased signal intensity, which is typically seen in areas involved by myocarditis. So early gadolinium is another sequence that we usually apply, and what we do here is we inject contrast and we scan the patient right away. And the areas of abnormal early gadolinium enhancement would then demonstrate areas of myocardial hyperemia or capillary leak. So this, for example, is a cine image. It's a movie sequence whereby we have injected gadolinium, and we can see that the lateral wall in the same patient with hyperenhancement in the lateral and inferior walls have also increased signal in this cine image. Again, this is after contrast administration. The final and probably the most important sequence that we use for myocarditis evaluation is delayed gadolinium enhancement, also known as LGE or late gadolinium enhancement. In patients with acute myocarditis, we expect to see necrosis, and in the chronic setting, we might see fibrosis. So an example of that is this case. This is late gadolinium enhancement. The normal myocardium should be black, and the areas involved with myocarditis or have necrosis would appear bright because of accumulation of contrast in these areas. So these are the main findings that we were looking for in MRI. Now there are other incidental findings that we might see that are important to look for in myocarditis, such as LV dysfunction and pericardial effusion, but these are things that can be seen with CT, with echo, with many other modalities. So the enhancement pattern in myocarditis is very unique because it allows us to distinguish myocarditis from other etiologies such as myocardial infarction. That's true most of the time, but not all the time. And I'm going to show you some typical examples. So the subepicardial late gadolinium enhancement is probably the most common pattern that we'll encounter. Again, this is a late gadolinium enhancement image whereby the normal myocardium should be black, and the areas affected by myocarditis would be very bright, as you can see here. And you can see that there's some sparing of the subendocardial zone, which is why we know it's likely not due to myocardial infarction, because in MI you would expect the subendocardial zone to be involved earlier rather than later. So typically the subepicardial pattern has been attributed to parvovirus B19. And this is the same patient, now showing you the 4-chamber view, again demonstrating this subepicardial involvement of late gadolinium enhancement in myocarditis. So depending on the etiology of the myocarditis, whether it's parvovirus B19 or herpes virus, you can have a slightly different pattern. You can even have a co-infection of 2 different viruses, and that's been seen in a large minority of patients. Eventually I'll note is Coxsackie-B, which is only comprised about maybe 1% of all cases of viral myocarditis, even though if you look at the literature back in 1979, it's actually thought to be the most prevalent cause of myocarditis. And that's since changed since we've gained the ability to perform PCR and analyze DNA and isolate viruses more successfully. So this is now a different pattern. This is an intramyocardial pattern of late gadolinium enhancement, where instead of having the subepicardial layer involved, we now have what's referred to as intramyocardial or mesocardial involvement. And what you'll see here is there's some sparing of the subendocardial zone, sparing of the subepicardial zone. So this intramyocardial enhancement pattern is typically seen in co-infection situations such as herpes virus 6, with or without parvovirus 19 co-infection. Another important point with this type of pattern is that the septal involvement has actually been found to be associated with worse outcomes. So these patients with septal involvement in myocarditis have more than 2 times increased hazard ratio for major adverse cardiac events. Same patient on 4-chamber view, again demonstrating that intramyocardial pattern. And this is now on T2-weighted imaging, again looking for edema primarily, and we again see this bright signal in the middle of the septum. I want to point out that bright signal can be normal within the lumen. Any areas that are filled with trabeculations or papillary muscles can have this bright signal mainly because of slow flow in the cavity, which then results in a registration as edema during MRI. So it's important to recognize artifact from a real finding. So here's, again, the co-infection situation with parvovirus and herpes virus. So another example of intramyocardial enhancement in a different patient, seen again on 4-chamber view. And this is another sequence that we very frequently employ. It's called a look locker sequence. And we basically change parameters from the beginning of the movie to the end of the movie. And that allows us to also demonstrate areas of abnormal enhancement. So sometimes it becomes very difficult to diagnose the cause of the cardiomyopathy. Here's such a case of myocarditis with classic intramyocardial enhancement. However, when we encounter a patient like this with a dilated left ventricle and intramyocardial pattern, it's actually quite nonspecific, meaning this could be due to non-ischemic cardiomyopathy, may also be due to ischemic cardiomyopathy. There's no way to tell, so it's very important to always do some coronary or functional imaging to determine whether or not this is due to coronary disease. Sometimes myocarditis can be very focal, so here's an example of that on a bright area of T2 in this infralateral wall. On late gadolinium enhancement, we see the same lesion, which is enhancing, and on early gadolinium enhancement, again demonstrating hyperemia in that same segment, and late gadolinium enhancement demonstrating again the same abnormality. So again, without proper history, it becomes very difficult to diagnose a case like this. This could simply be metastatic disease, it could be sarcoidosis. So really the clinical history is very important in allowing us to narrow down the differential. Another case of a patient with a very focal enhancement. This is another area. So very focal enhancement. On early gadolinium enhancement, not much is seen. So early gadolinium enhancement is actually a sequence that was very strongly advocated in the past, about 5 years ago, but I'll tell you more about the newer guidelines in a moment. But this is actually one of the sequences that's been removed from the newer guidelines, even though it was very popular about 4 or 5 years ago. So another lesion, very focal, can look like sarcoidosis. And on SSFP, you really don't see much of any abnormality on these cine images. No, seems like a normal wall motion, and maybe a little bit of thickening in that area. Again, can easily mimic sarcoidosis in the appropriate clinical setting. Another case, there's a patient with a dilated left ventricle again, but very thick myocardium with just a very focal area of enhancement. And again, on cine, there's really no abnormality visible in that focal area. There's another case that becomes tricky when we're trying to distinguish myocarditis from myocardial infarction. Now, the subepicardial distribution is typically very easy to distinguish, but once you have a transmural late gadolinium enhancement in cases of severe myocarditis, they become really identical in imaging features to ischemic cardiomyopathy. So again, transmural delayed enhancement, this could easily be RCA occlusion resulting in transmural infarction, but this turns out to be a case of myocarditis in a patient with non-obstructive coronary disease. Different patient now, if you look at these walls, this looks to me like almost a circumflex OM distribution, maybe a dominant circumflex occlusion, causing this hypokinetic or akinetic wall. But as it turns out, this is a patient with myocarditis, again, non-obstructive disease, can mimic really myocardial infarction in terms of the wall motion abnormalities, but on delayed enhancement, we can see that even the anterior wall has transmural involvement, just a very severe case of myocarditis. Sometimes it can be multifocal. So this is a pattern initially that might seem like the classic intramyocardial pattern that I've shown you many times before. But when you look at the long axis views of these cases, they're actually very interesting. They look like tiger stripes or zebra stripes. You can see some areas of fibrosis or necrosis intermixed with normal myocardium, and then again, alternating patterns of fibrosis and normal myocardium. So there's a very interesting pattern. We see that occasionally, again, commonly seen with co-infections of both herpes and parvovirus. Early gadolinium enhancement will also sometimes show the same pattern. You can see these alternating areas of hyperemia and normal myocardium. So different example now, again, multifocal involvement. On T2 weighted imaging, sometimes it can be very difficult to diagnose. For example, here I can see what looks like edema. This area of abnormality is not so obvious. I could easily oversee this on T2 weighted imaging and not call this. But on delayed enhancement, then you see these areas of abnormal contrast uptake. So as it turns out, when we look at the accuracy of MRI findings and trying to help us make a diagnosis of myocarditis, late gadolinium enhancement really leads the pack. The range is quite high because there are some cases where there's no enhancement, but turns out the patient does have myocarditis. And it's a known phenomenon that in about a third of patients, they might not have any scar at all in myocarditis. One of the things that, again, was very popular about 4 or 5 years ago is the evaluation of early myocardial enhancement, and usually this is done by comparing the signal in the myocardium to that of skeletal muscle. This has fallen out of favor, and the most recent guidelines in 2018 has actually eliminated this, even though it seemed like a very high performer back when it was first introduced. T2-weighted imaging for edema is not as strong as these first two. And finally, non-specific findings, as I mentioned before, LV dysfunction and pericardial effusion. So these are the drawbacks of these different types of sequences. With the late gadolinium enhancement, I mentioned before that they can be undetectable in some cases of myocarditis. The early global enhancement ratio, which is again measuring the signal of myocardium and comparing to skeletal muscle, can be very tricky because the reference point, specifically the skeletal muscle, is quite heterogeneous during an MRI. If you look at this particular case, you'll notice that some of the skeletal muscle is very dark, some of the skeletal muscle is very bright. So if I were to compare this myocardium to skeletal muscle, how do I know which muscle to choose? Do I choose the dark muscle, the bright muscle, somewhere in between? It's a very inconsistent type of series and not really easily reproducible. Finally, T2 edema is also another problematic sequence, and so investigators have sought to look for a different way to quantify areas of abnormality during myocarditis. I just wanted to point out another case of late gadolinium enhancement. In acute myocarditis, you can often see large areas of necrosis. However, in the chronic setting, when the necrotic areas shrink down, they may be too small to detect on MRI. And I'm going to show you some examples of this. So here's a classic example. A patient scanned initially showing the subepicardial enhancement, the typical distribution. They come back 4 months later, and we still see that same pattern. The abnormality never went away. In the second patient, you'll see that they had initially the subepicardial pattern, but when they come back 3 months later, it looks completely normal. So sometimes in the case of a chronic myocarditis, you may miss the fact that they had myocarditis because there's no more enhancement when they come back a few months later. So this consensus criteria was developed back in 2009. It's called the Louise consensus criteria. It was mainly developed to allow MRI imagers to determine what's the best sequence to use to identify myocarditis. So the criteria basically states that you need to find at least 2 of these 3 in your study for you to strongly suggest myocarditis. So they include T2-weighted imaging edema, this early gadolinium enhancement ratio, which again in the 2018 guidelines has been completely eliminated, and the non-ischemic late gadolinium enhancement pattern, which is probably the strongest performer of these 3. It's found that it improves the accuracy of diagnosing myocarditis from 68% to 78% compared to just late gadolinium enhancement alone. However, this number is still really not that great, and we'll just show you some examples. For those of you who have not heard of Lake Louise, it's this huge, beautiful lake in Alberta, Canada. It's a very famous ski resort. But anyway, people have decided to modify the Lake Louise criteria again because the skeletal muscle reference is very hard to reproduce. So, for example, in this publication, 2014, the investigators decided to use early gadolinium enhancement using the cine images, which were the images that you saw earlier, as opposed to just comparing to skeletal muscle, because this was found to be a little bit easier to reproduce. So in 2008, December 2008 specifically, there's a revised Lake Louise criteria. And what they've done with this revised criteria is essentially remove the skeletal muscle myocardium comparison reference. And instead they report that 2 of 2 criteria now must be present for a strong MRI diagnosis of acute myocardial inflammation. And the 2 primary criteria are abnormal T2-weighted imaging or T2 mapping, as well as abnormal either T1 or late gadolinium enhancement. These are combined together, T1 as well as late gadolinium enhancement. Now, we haven't really talked much about T1, and so that's something I'm going to describe a little bit today. Don't worry, there won't be too much physics in today's talk. But basically what T1 is the time that it takes for hydrogen atoms to return back to their original position after they've been misaligned or disrupted by a magnetic pulse. So what happens is initially the hydrogen atoms have a certain magnetic direction that they're facing. When we apply a magnetic field to these atoms, they can tilt and spin, and that will result in a decrease in their magnetic strength. And when they line back and reach back to their maximum magnetization, that amount of time, that duration is what we refer to as the T1 relaxation time. And in general, any areas that have edema will increase not only T1 but also T2 relaxation times. So there are different techniques that have been described in literature to analyze or measure the T1 relaxation times. The most popular sequences are called MOLLI and SHMOLLI, that stands for Modified Look Locker Inversion Sequence, and this is shortened Modified Look Locker Inversion Sequence. And the difference is that we are basically compromising or trading off between a long breath hold and better image quality versus a shorter breath hold and slightly degraded image quality. So in general, in patients who are not able to hold their breath, this would be the better sequence to acquire because it only takes 8 seconds of a breath hold as opposed to this, which takes almost double. Unfortunately, this will lead to higher noise and potentially decreased precision during measurement of abnormalities, and we'll go through those images in a moment. Once we've acquired the images, next thing we're going to do is basically try to characterize the tissues based on either whether or not we inject contrast and whether or not we have a hematocrit value that we can use to measure extracellular volume fraction. So there's 3 ways to analyze the data once you've collected the images. And I'm going to show you some examples of those. The point being that using this type of tissue characterization can potentially improve diagnostic accuracy compared to traditional Louise criteria from 2009. So these are the 3 different types of analyses that can be performed using T1 mapping sequences. First is a non-contrast T1 map. So for example, in this patient with myocardial infarct, this is not a myocarditis case, but rather an infarct case, you can measure the normal myocardium and have a T1 value of 938 milliseconds. Compare that to the infarcted myocardium, which is a higher T1 relaxation time, and that would be one way to distinguish normal from abnormal. Another type of analysis, which is done after contrast, which is a completely different analysis. Again, you'd be able to compare normal myocardium to infarcted myocardium and then decide whether or not that's a useful comparison. Finally, a third way to analyze it would be the ECV map. Again, comparing 2 regions, but with the addition of hematocrit to determine whether or not this is a useful analysis. So 3 different methods of analysis. The ECV map is actually a combination of both T1 map pre-contrast and post-contrast. What that means is this is the most difficult analysis to perform because you would need both this data as well as this data in order to come up with this data. Just to give you an example of what these look like when they're being analyzed, so we have this initial map that you can see here. This is the delayed enhancement sequence showing you this scar in this patient with myocarditis. It's in the basolateral wall. And there's a study that's done post-contrast, so areas with fibrosis will demonstrate a shorter T1 relaxation time. So if we measure the cavity, it's around 75 milliseconds T1 relaxation time. The normal myocardium is around 154, and the area that's potentially diseased or contains fibrosis is around 130. You can see the difference is not that great. It's 150 to 130. But that's basically how T1 mapping works, is by comparing one myocardium to another, you could potentially diagnose that abnormality. So again, 3 ways to analyze it: T1 map without contrast, T1 map with contrast, and extracellular volume fraction, which is a combination of these 2 plus a hematocrit to come up with the severity of edema. So when people have looked at these and compared them, T1 mapping without contrast is actually the most superior technique, which is quite interesting because, as I mentioned before, extracellular volume is a technique that requires a lot more effort, requires T1 as well as post-contrast T1 analysis. But as it turns out, T1 is very similar to late gallium enhancement in terms of the area under the curve for accuracy. So they're very similar. That's from one study in 2013. There's another study, also in 2013, again comparing T1 without contrast, which is probably the easiest of these mapping techniques to perform in terms of analysis. It performs much, much better than all these extracellular volume analyses, which are much more difficult to perform. So at this point, most people for myocarditis are really turning away from extracellular volume as being a helpful tool compared to T1 mapping. So people have even tried to compare acute versus non-acute presentations, acute and non-acute referring to how long the symptoms have been present, and usually the cutoff is around 14 days. If people have had symptoms for more than 14 days, it's considered to be non-acute or subacute. And again, if you compare one group versus the other, you see that native T1, which is a non-contrast T1, is a better determinant of whether or not myocarditis is present. So one of the criticisms from criticism for many of these publications is that the clinical findings have often been used as the gold standard. Specifically, patients who have recent ongoing myocardial injury from elevated troponin and suspected viral etiology due to absence of coronary disease are used as a gold standard. So some critics would say, how do we know these patients don't just all have Takotsubo or some other disease that's unrelated to viral myocarditis? And so that now is the segue for this trial that was performed and published in 2016 called the MyoRacer trial, where they actually performed biopsies in over 100 people with suspected myocarditis. Most of these procedures were performed and analyzed in Germany, but you can see that in patients with acute symptoms compared with chronic symptoms, T1 pre-contrast, which is native T1, is still a very good performer in the acute setting. In the chronic setting, native T1 actually drops down, and instead T2-weighted imaging becomes a better predictor, which is actually quite interesting because T2 is normally an indicator of edema, and even in chronic symptoms or chronic setting, for some reason T2 edema is still a better predictor than the others. So these are basically the reasons why the Louise criteria have been updated, and we removed the skeletal muscle comparison, and we include the involvement of T2 mapping in generating the requirements for MRI diagnosis of myocarditis. So again, if you compare the area under the curve, the top performers are really T1 mapping and late gadolinium enhancement. Here again, if you combine the two together, there's a very high area under the curve of 96. So again, the advantages of T1 mapping are that it does not require intravenous contrast. It could have greater accuracy than the Louise criteria, and it may potentially help distinguish between diseases. And I'm going to show you some examples of that. Limitations of T1 mapping is that it's highly facility dependent, meaning if I have values for T1 mapping at this institution that I consider normal, at another institution, another magnet, another MRI scanner, it might be completely different. So normal at UW, for example, might be 950, and normal at Cornell or New York City might, for example, be 900. So it's very difficult for guidelines and consensus groups to come up with what's considered normal and how to perform that cutoff if it's truly scanner and machine dependent. The other problem is that many diseases actually have overlap between different levels of T1. So for example, ideally you want certain diseases with higher T1s to be distinguishable from other diseases. Unfortunately, there's a lot of overlap again between diseases, and it makes it very difficult to apply T1 in clinical practice. I'll give you some examples here. So in healthy subjects, for example, various studies have reported different values around 950 to 960, and note the standard deviations are quite high. And in patients with myocarditis, it's 990, which is really not much different from a normal subject, especially when taking into account the standard deviations. And I'll show you some other cases that reflect this type of challenge when it comes to T1 mapping. Other diseases like dilated cardiomyopathy, hypertrophic cardiomyopathy, again, show very similar high levels, but again, may be a little bit difficult to distinguish from another due to similar numbers. So you can also have patients with coexisting diseases. So there's a patient with known myocardial infarction, he even has a left apical thrombus there, but they also have myocarditis, and so they have this abnormal intramyocardial enhancement. And so in these patients, how do we know which diagnosis to give based on just T1 mapping? So prognosis. One of the studies that has been published demonstrates a higher rate of adverse cardiac events in patients with larger areas of late gadolinium enhancement. So for example, when the areas of gadolinium enhancement exceed greater than 17 grams, you might find more areas of, more incidents of adverse cardiac events. So similarly, if you're looking at myocarditis and looking at ejection fraction in presence or absence of late gadolinium enhancement, studies have shown that even within the greater than or equal to 40% EF category, the presence of gadolinium enhancement will more than double the incidence of cardiac adverse events. And when we're looking at patients with lower ejection fractions, less than 40, again, the presence of late gadolinium enhancement will almost double the event rate. When you look at the survival, people have seen the same thing following patients for up to 10 or 12 years. You can see really a good ability to stratify patients based on the findings on MRI. So challenges in practice. I just wanted to show you how T1 mapping is performed and the results that we usually get. See, here's an example of the software that we typically use. This, by the way, is the software that pretty much every single publication has used to analyze their T1 maps. And when you launch a software, the first thing that you're greeted with is actually this red line. And it's going to magnify what this red line shows. It says that the T1 module is not for clinical use, which is a little bit of a problem because that's what the guidelines say you should use clinically. And that, again, is a software that everybody uses pretty much throughout the world. So here's an example of a patient with myocarditis. I'm going to look at the inferior wall here, which has this classic subepicardial enhancement. You can see this abnormal signal, abnormal enhancement. And I'm going to try to evaluate the T1 map for these areas. So this is my T1 map. And what I'm going to do is I'm going to trace the myocardium, which I've done here, and it tells me that the global myocardial T1 map, just averaging all the pixels here, is going to give me a value of around 958. And you'll notice that the standard deviation is really high, it's 113. So you're thinking, you know, why is it so high? That's actually considered to be normal. This study is very noisy, as you can see. The resolution is not that high, and that's a typical standard deviation that you would see from T1 mapping on a patient-by-patient basis. Now, when you look at the regions of interest of the normal myocardium compared to the potentially abnormal areas because of our delayed enhancement region, you'll see, for example, that the region of interest in the normal myocardium is lower, 945, higher myocardium, it's 969. So if you look at these numbers, if you average these two numbers, it comes out to 958, so everything looks perfect. The normal areas have low T1 map relaxation times, whereas the abnormal areas, which is the blue area, has abnormally high T1 map relaxation time. The problem is this is very subjective in terms of how you trace these regions of interest. It's very user dependent. So I'll show you an example of what happens to these numbers when I try to slightly change these regions of interest. So I'm going to go from this number, 969, and I'm going to make my region of interest slightly smaller. And look what happened to my numbers. They now show that there's no difference between the diseased area and the abnormal area. So again, I'm going to compare the previous tracing, the previous number, to the new tracing. So if I don't know any numbers and I'm just doing this blindly as part of research, how do I know which tracing to keep? It's a very interesting question. I'm actually not sure how investigators do it because, again, small changes in your tracing will drastically affect your map values. And again, that's not even taking into account the standard deviations. So that's one of the challenges that we have now with T1 mapping. And with that, I just wanted to show you again this comparison between healthy subjects and myocarditis. You'll notice that there's no standard deviation shown here. These are standard deviations shown between patients, but the standard deviation within each patient is actually very high. It's usually about 100. So that's one of the challenges that we have right now for T1 mapping. And with that, I just want to conclude. Cardiac MRI is a powerful tool for the diagnosis of myocarditis. Native T1 mapping has great potential for the accurate diagnosis of acute myocarditis. The area under the curve is quite impressive compared to other parameters, including the Louise criteria. And future advancements in imaging protocols, or perhaps artificial intelligence, can aid in risk stratification and management decisions. And this is my former group in New York. Some of you may recognize Dr. Javier Sanz. He's one of the cardiologists that we work with and director of the cardiac CT-MRI program over there. Gina Rocca, one of the congenital heart disease experts over there. And so with that, I'd like to thank everyone for your attention.
Thank you. Question? Yeah.
So try to look at the use of this clinically. I mean, so the areas under the curve are helpful for looking at the whole population. But
sure.
If I send my one patient for a scan and it comes back positive, I mean, what is the positive predictive value of the test?
So again, it would depend on the enhancement pattern. If it's a subepicardial distribution, we're usually very confident that not much else besides myocarditis can do that. Sarcoid occasionally, but myocarditis is would be very high on the list. And also depends on the pre-test probability. So in someone with an elevated troponin, that would probably eliminate sarcoid as a potential differential for that enhancement pattern. So it's very high yield, especially in the setting of prior chest pain or suspected myocarditis based on troponin. But if the enhancement pattern is transmural, like some of the cases that I showed you, it's very difficult to tell based on imaging alone that it would be myocarditis because potentially it could be metastatic disease, could be transmural myocardial infarct from coronary disease. So in general, I would say 70 to 80% of patients with myocarditis enhancement will demonstrate that subepicardial pattern, which is a good thing, meaning there's a fewer percent of cases that will look like myocardial infarct.
So then the converse, if I send my patient and their MRI is normal, does that mean they don't have myocarditis?
No.
Your chronic figure looked like
Exactly.
it was approaching the line of identity, which means it's of no value at all.
Correct. They could still have myocarditis, and that's one of the reasons why people decided that maybe T1 mapping is good, because apparently T1 mapping could be abnormal even in the absence of scar. So that's one of the main values of T1 mapping. The question now is, how can we accurately measure T1 mapping?
I believe Dr. Stephanie O'Hara.
How useful is this technique for acute rejection in transplanted hearts? We sometimes rejection's patchy. We come across cases where we have negative biopsies, but we're clinically very convinced there's rejection. Is it a useful technique for us to use?
So I don't know much information about the T1 mapping for rejection, but potentially that could be useful for that. Correct. So there's potential, but again, because of the overlap that we see, for example, dilated cardiomyopathy and hypertrophic cardiomyopathy have very similar signals. So I don't know if rejection, for example, in proven case of rejection, whether the T1 maps would be similar to other diseases, in which case it might be difficult to determine whether or not it's due to rejection as opposed to someone who happens to have myocarditis and the heart transplant.
There is an ongoing clinical trial, or there's an ongoing prospective study looking at T1 mapping for rejection. I don't believe that's out yet, but I think it's something worth looking at. Yeah, Richard?
Matthew, so that was a great talk.
Thank you.
I'm curious, so a lot of the cases you showed are really cross-sectional. There was very few where there was follow-up. I'm curious in a clinical setting, so we see a lot of patients with acute myocarditis. In terms of follow-up, what's the most accurate modality? Is it T1 mapping? Is it T2? Is it LGE? Because you hear a number of different things. It's a little bit unclear what the best method as it relates to follow-up these patients. And is MRI really useful for follow-up?
Right. So in my experience, most of the patients actually do not have follow-up. So I showed you a few cases where some of the patients with follow-up had the same amount of scar. Some patients had less scar or no scar at all. Those are really the minority of cases. Most of the patients we've encountered actually do not get MRI follow-up. Once the myocarditis is diagnosed or not diagnosed, they do not come back for a subsequent exam.
And if we do follow-up though, do you use a combination of them?
Oh, usually when patients come up for myocarditis evaluation, we usually run all the sequences that I showed you. So we don't pick and choose which one to run. We'll run all of them and then report the results of each sequence. T1 mapping is something, again, that we don't report clinically, mainly because of the challenges that we have. We don't want to shoot ourselves in the foot and say, oh yeah, this number is abnormal, when in fact it's just very user-dependent. And you could change the numbers to anything you want, as I showed you in this example. You could make it abnormal or normal, depending on how you trace those circles. Even slight changes will affect it a lot.
One thing that I think all of us here would like to have more T1 mapping incorporated into our clinical reports. One of our vulnerabilities has been that we don't, as you pointed out, we don't quite know what the normal T1 range is for our scanners at our institutions.
Yes.
So I'll use this as a brief plea, which is we're going to need to put a bunch of volunteers in our
healthy volunteers
and get T1 value ranges for healthy volunteers, native. We won't give contrast for that. I would imagine.
Exactly. No contrast needed.
The native T1 for our 4 scanners. So we might be sending out an email at some point looking for volunteers once we get an IRB and things like that together for it. But if anyone's interested in knowing what their own T1 value is, there are potentially expect an email and know that it'll help our clinical MRI reports.
Absolutely.
What?
The IRB's ready.
For that?
We've got it.
Excellent. Excellent.
I have a question.
Sure.
I have one last question. What about inflammation other places? Because we deal with a lot of aortic disease.
Yes.
And it's been really difficult to diagnose aortic inflammation. Are you going to be maybe trying to do that as well?
So aortic inflammation we can evaluate either using contrast. In terms of T1 mapping, I think the odds of that would be very small just because the aortic wall thickness is so thin. I would say the aortic wall thickness, even in inflamed cases, would be similar to the right ventricle wall. It's very, very thin. And you've seen how small changes in tracing can change the value so much. So when you have a region of interest that's that small, it becomes even a bigger risk of getting inaccurate or non-representative numbers. So it might be difficult. A lot of the T1 mapping studies have actually been all done on the left ventricle only. People hardly ever trace the right ventricular walls because they're very thin and they're very difficult to trace. Sure.
Since the Lake Louise criteria are using like T2 mapping as a line item rather than T1 mapping, is that prone to the same variance between institutions and between scans that T1 mapping is?
Yes, T2 mapping. I'm actually surprised that they sort of added that as a requirement because T2 mapping to me is very finicky, almost maybe even worse than T1 mapping in terms of reliability. There's actually very few studies that have looked at T2 mapping. There are only two, and actually in that updated criteria in 2018 Lake Louise publication, they only found 2 studies that look at T2 mapping in terms of being high quality studies, as opposed to the other sequences which have dozens and dozens of studies. So that's something that I think requires more investigation. It's more finicky than T1 mapping in terms of user confidence and subjectivity, but they found it to be useful in general.
Yeah. So I think this leapfrogs on some of the other questions. What is the underlying cause of this extensive variability in scanner-specific and center-specific T1 values in native myocardium?
Right. So MRI machines are very interesting because it's very difficult to control the signal that the magnet is trying to record. That is, you could be sitting, for example, in a room and someone opens a door and all of a sudden the signal changes. It's a very finicky machine. So the difference is really due to the minute differences in how the machine was built. For example, if you buy one car and another car and you try to race them, even if the same exact model of car, one car might be slightly faster than the other. So it's those intrinsic differences in how the machines are made, which is what causes the differences between one machine to another. So even in this 2018 Lake Louise criteria, they actually didn't specify what normal T1 is called because everybody recognized that normal is different from one machine to another. So here, for example, we have about 3 MRI scanners that we use. We would have to test each of those scanners to see what the normal is for every scanner, which was one of the things that makes it very difficult to employ T1 mapping. T1 mapping is actually not a new technique. We had this technique, I would say, 15 years ago when I was at Cornell, and we had this similar difficulty. We tried to use T1 mapping for amyloidosis. We had similar difficulty. We would have normal patients we could easily make them look abnormal by changing our tracing. So it's not exactly a new test, but that's one of the reasons why it's still not approved for clinical use.
So if each patient gets all these different sequences, have you explored sort of combining them, co-registering the images, and trying to see if you can tease out more or synthesize more information about the specific details of each patient's substrate by looking at, for example, like the T1 values, which are sort of relatively absolute, versus the LGE values, which are ratiometric?
When you say comparing them, you mean comparing normal myocardium versus fibrosed or necrotic myocardium?
Well, I would imagine that you could combine the knowledge gained from the T1 scans with the information in the gadolinium enhanced images.
Oh yes, that's definitely been done. So I'm just going to point out one of the slides here that I had where they actually compared different combinations of those tests. So here, for example, these are different studies. These are how many studies have been done on various combinations. So you can use either original Lake Louise, which is mainly based on T1, late gadolinium enhancement, T2 rated imaging, and the skeletal muscle reference, early gadolinium enhancement, and various combinations. So the combination including T1 mapping and late gadolinium enhancement is thought to have the highest area under the curve when these two are combined. So that's been looked at, and that's one of the bases for the strong push for T1 mapping. Sure.
I have a question on that same vein. What about arrhythmias and heart rate? Does that affect T1 mapping values as well?
The heart rate definitely affects T1 mapping. So in the formula for T1 mapping, when we do these analyses, the software actually requires us to enter the heart rate. So if the heart rate is blank, it might not be able to perform the mathematical correction properly. So the heart rate's definitely a factor in the generation of this T1 map value.
What about arrhythmias, like atrial arrhythmias, flutter, the irregularity?
So the irregularity, that definitely will affect the image quality, which I would imagine downstream would affect the ability to precisely measure values. I'm not sure if that's been studied, whether the irregularity would affect the map, but definitely the heart rate does have an influence on the T1 map. Someone else? Yeah.
Yeah, I just want to echo what Eric said about how happy we are to have you here and
thank you.
look forward to absolutely wonderful collaboration. Putting together some of these comments, I was wondering, clinically, when we have a patient coming in with myocarditis, what is the optimal time to get the MRI, sort of considering all of these different things
Right.
for the best diagnostic yield?
So from the data that we have, especially the ones that were biopsy-proven, it seems like the acute myocarditis patients are better diagnosed with the tools that we have. So I would say within 2 weeks of symptoms would be the best time to image them. So that's actually shown by this graph over here. These are the different tests that we're employing, the different series that we have in our armamentarium, and you can see that the tests perform better in acute patients, and they don't perform so well once they're beyond the 2 weeks of having symptoms. So that's my suggestion. I know that there's a backlog or a queue for ordering MRIs. People have told me before it takes a month for the patient to get in a scanner, but I think if you call us and let us know it's urgent, we'll try to bump things around to see if we can get your patients earlier. You can definitely give us a call anytime.
David? Yeah, that was my next question about how this is sort of moving forward and how we can actually accomplish this. Great answer.
Oh, thank you.
David.
Given the large variability between scanners and settings, is there an opportunity for a type of phantom to normalize the results, just like with INR?
Right, so that's been recommended by the Lake Louise crisis. So in that December 2018 guideline, they're hoping the vendors will come up with a way to equalize all of them, but we know these things will take time because the vendors are competitive. They generally don't want to share their inside secrets in terms of how their scanners are made and built.
Well, why are you dependent on the vendors? I mean, this is chemistry, and you should be able to have a university department just create a phantom.
Right, but the problem is if every vendor has a different number, then the different institutions or different hospitals would still have different normals.
Just measure the phantom in all the different vendors.
Oh, I see what you mean.
Make the same phantom.
Right.
Don't ask the vendors to make
Right.
the phantom, you make the phantom.
You make the phantom. That's certainly a possibility. So that was mentioned in the guideline as well, that they want the vendors to make phantoms, but that's certainly a possibility. Right, right. Well, we probably help with some biomedical engineers and physicists, but that's certainly on people's minds. That's a good question.
No one else? All right, well, Dr. Chan, thank you very much.
Thank you.